So, like I said, my name's Vishnou on the endocrine diabetes registrars in London. Um, I think I've delivered this clinical consultation and I try and think about different ways of trying to deliver it. But I do think the basics and the fundamentals which I want to share for people who have never come to one of the webinar series is important. So the aim of this session is just to talk about PACES examination in general, the exam, not the examination stations. Suggest approach to the clinical consultation stations and my sort of tips to maximize success. I have three practice scenarios today, so I do really hope if we've got some sort of brave volunteers, there's sort of more people trickling in on the call, but uh, you know, in a non-stress-free sort of like setting, if people would volunteer to just do the scenarios on a webinar, that'd be amazing, just so that's it sort of helps everyone learn. And I want people to feel like they can ask questions throughout. So I will have a look at the chat and I'll answer the questions as we go through. Just as a brief reminder, if in case you've not been sick of this already, this is the PACES webinar, PACES carousel for the current exam. And station two and station five are the consultation stations. Now, I want to draw your attention to two things. So, just in terms of position where they are on the carousel. So, in that 5 minute interval, you actually get the scenario. So, you get just that preparation time. The second thing I want to point out is actually on the right of the screen. And on the right of the screen, it tells you which skills are assessed. And I want to just emphasize the fact that all skills are assessed in the clinical consultation. And therefore, the clinical consultation carries significant weight for the entire PACES sit-in. So if you do not have a good clinical consultation or you do not do well in both of the clinical consultation, the chances of you passing PACES are minimal. So these are good, important stations to demonstrate all your skill sets and pass the exam overall. So, what is the consultation station? So, like I said, you have 5 minute interval to read a referral letter, usually from GP or someone to prepare for the station. So, the station itself is 20 minutes. So, the 15 minutes is to include history exam, discussion with patients. So, patients got a list of questions they're going to ask you. So, it's all written down, it's all prepared. And I'm going to actually try and show you some of the what they have. So, just so you're aware, like the detail and that is possible here. And the last 5 minutes is sort of viva. So it's sort of summarizing the case, talking about differentials, talking about what your approaches are, and just usually an opportunity to, in case you missed any marks or points in the earlier sort of 15 minutes to get those points. Just as an FYI, you will get a reminder at 13 minutes. So when you have 2 minutes left of the 15 minutes. Um, those 5 minutes in that 5 minute interval before you even enter the station are really, really key because it's your chance to ask or work out what questions that you want to ask in your focused history. Because remember, you've got 15 minutes to do quite a lot. It's also about which examinations you're going to do and which part of those exams are important. So you don't always have to do a full system exam. If, for example, the patient has only one system as a problem, then you should or you could do the full examination in that system. But for example, if you're expecting yourself to do a full neurological exam, cranial nerve, upper limb, lower limb, in as well as asking a history and discussing with the patient all in 15 minutes, I think you're setting yourself up for quite a difficult task. So here's my work through example. Um, so on the left is what a referral letter looks like. Okay, so it's usually at the top, it usually says what the patient's initials or name is usually, and then it tells you where you work in the hospital. Okay, and that's really important. So you need to know, are you in an outpatient setting? Are you in the emergency department? Are you in a medical assessment unit? Okay, so it's really important to know where you are in the hospital. Um, and we'll come back to that in a second. So they have a presenter complaint, and they will usually have some observations. Sometimes they have blood tests, but it's usually observations. So the story here is this doctor, dear doctor, man, it's actually rarely, so it just tells you that even the real PACE examples have typos. Attends our surgery, although he had an MI 8 years ago. So history of myocardial infarction, and his presented complaint is worsening breathlessness. I found him to be tachycardic, but could hear no abnormality on auscultation. Great. We're going to still listen to the chest, the heart ourselves, aren't we? I would be very grateful if you could see and advise. Those are his observations. And at the bottom, it tells you the things that you're expected to do, which is pretty much the same every single time in each scenario. But do read it just because sometimes it can be slightly different. Right. So here's my thoughts in the preparation time. Present a complaint worse than breathlessness. It's got a past medical history of an MI 8 years ago, so that's important. Let's just think about the observation. So he's tachycardic, so we don't know if it's irregular or not. We don't know, whether this is an arrhythmia, whether that's causing breathlessness. His blood pressure is quite high, and we do need to address that. So we do need to think about whether he needs more blood pressure monitoring, whether he needs some treatment for that, because it's unusual, because to be that high, or whether he's in pain, for example. SAT's 98% arrhythmia. Okay, good. And respirator 14 and he's afebrile. Okay. We're in the medical assessment unit. So we're inside the hospital. So we're in a place of safety. So we don't need to move him from the outpatient setting into the inpatient setting. We're already in there. Okay, so that's useful. Now, our history. So our preparation for the history is going to be determined by a differential diagnosis. So what we need to think about is what our differential diagnosis is. So I've just written down so I sort of did this as an exercise myself a couple of months ago, actually. And I just thought what were my big differentials. So I include things that are high risk, so pulmonary embolism, and I include things that are likely. Okay. So the likeliest thing in my head was that this patient's got heart failure, right? He had a previous heart attack 8 years ago. So I'm going to ask him discerning questions. So what I mean by that is not just about leg swelling, I'm going to ask about orthopnea and PND. Those are two sort of discerning questions, aren't they? How many pillows does he sleep at night? Those sort of questions. Does he have any exertional breathlessness or is it at rest as well? Then I'm going to ask about chest pain because of the previous MI. And I am interested in arrhythmia. So I just need to know, we're going to have to think about how we phrase the question around that. Now, respiratory is the other thing. Has he traveled anywhere? What are his VT risk factors? Any family history of clots? Pneumonia, it's unlikely, but we're going to ask him about cough, aren't we? And we're going to ask about fever and whether he has any smoking history, because that's the other thing that could explain breathlessness. Okay, so that's just my quick sort of differential list um, that I've sort of come up with. Okay, now other things, and these are just again thinking laterally. Hyperthyroidism, it's not just because I'm an endocrine diabetes registrar, that's something that could be important here. And anemia. So we're going to ask him some constitutional symptoms. We're going to quickly go through past medical history, social history, and family history. Now, here's the next bit, the examination bit. Sorry, so I suggest that we shouldn't do a full cardiac exam, but we're going to sort of shift gear. Okay, so depending on the history they give us, so if we think they've traveled from Australia, for example, 2 weeks ago, so PE is higher up on the differential list. I'm not entirely, it's not entirely useful to do a full respiratory examination and full cardiac exam. We're going to try and pick and choose a bit. Okay, so listen to the front and back, for example. We're putting ourselves under a lot of pressure. So I would try and do a focused cardiorespiratory examination. Okay. And I wouldn't do tactile fremitus and vocal resonance. I wouldn't do all of those things. Okay. Because I need to get onto the calves. I need to look for signs of DVT, right? So that's purely dependent on the history. Whereas if the signs are more suggestive of COPD, or even if it's sort of pulmonary fibrosis, then I'll spend a bit more time on the chest. Okay. And I would do maybe less cardiac. So I wouldn't do collapsing pulse, for example. So that would be pushed away. So a lot of this is judgment and a lot of it is dependent on the history. But I know in my head that I am going to do some semblance of a cardiac exam and a respiratory exam. Okay. And the only curveball to all of this is if it suddenly becomes hyperthyroidism, then I'm going to have to shift to a thyroid exam. Okay. So can you see how I'm already trying to prepare myself for the eventuality of doing certain examinations here, and I'm selecting what I will likely need and what I don't likely need. Now, investigations. So, um, when I say try and integrate your location into the hospital, so if you ask for a cardiac monitor and you're in an outpatient setting, you need to mention that you're moving the patient into a place of cardiac monitoring. Okay, so this is the point about this exam. This exam is trying to for the consultants who examine you or the senior registrars to determine whether you could be a registrar. Okay, that's the point of this exam. I would suggest that you should always ask for a full set of repeat observations, an electrocardiogram, urine dip, a full set of hematobiochemistry, and then you can go through the ones specifically and just, explain why your thoughts are. I think this patient's probably going to need an echo in the context of a previous myocardial infarction. And if you think PE, then you have a decision to make about D-dimer and CTPA, and that's all dependent on the Wells score, as I'm sure you're already aware. Um, but you see, we've even got our list of likely observations to cover those differentials that we made already. And this is all within the 5 minutes, okay? So when you do these stations, you'll get faster at this. But we've answered some of the key questions in the Viva already. Okay, so we've sort of planned our consultation. Right. So this is actually from the prompt side. Okay, and I was very keen to show you this because this is what the patient will tell you. Okay, so some of the stuff the patient will not tell you unless you ask a specific question. So, for example, if you do not ask about a cough, they will not tell you about sputum or blood. Okay, they will not tell you that. Um, so, breathless when climbing on stairs. There is a trip to Australia. Um, Become tired and breathless, dry cough, no chest pain, no palpitation, no dizziness. Socks are tight but no painful calves. Appetite is unchanged, and you do not think you put on weight. So we're sort of getting potential heart failure story, but because of the recent travel, you peas in the back of our minds. Okay, so this is the past medical history in full. This is the drug history, the family history, the allergies. So they have loads and loads of data to tell you, okay? And you have to be able to get through this quite quickly, okay? So that's what they have on their sheets of paper to tell you, okay? They have AF, um, usually. So what I've shown you here is what happens in real life. So this history can actually be played by a patient who does not necessarily whose history is not necessarily that patient's, and they will adapt it slightly, okay? Because it doesn't matter if the patient's got a murmur or a pleural effusion because it doesn't change the underlying diagnosis as far as they're concerned, okay? So, but they usually want someone with atrial fibrillation in this scenario. Now, what you have to address is that the patient has concerns, so they will ask you this question about what is causing my breathlessness, and they could ask you, could I have lung cancer? Okay. And if you answer those questions well, they will also ask you, do I have a serious heart problem? Okay. So especially if you talk about heart failure, they will ask you that question. Again, you have to get to this point of them asking you this question and you being able to answer it to score maximum points in this clinical consultation. Um, please do post any questions that you have because I do want to be very clear that this is the other side, the flip side, as it were, of the PACES exam. Right. So this is the MART scheme. Okay. So the MART scheme has all of these differential diagnoses: AF, congestive cardiac failure, PE, ACE-induced cough, um, pneumonia. Okay. And they want you to say those investigations, okay, or at least consider those investigations. Now, can you see a lot of these investigations are things that we already thought about beforehand? Okay, so we're going to get, we should be able to get full marks in the clinical judgment if we did that preparation correctly. We didn't necessarily think about all, well, I certainly didn't. I didn't necessarily think about all of the differentials here. I missed out ACE-induced cough, but that's not going to be the reason. You're not going to lose any marks for not getting all of them. Okay, so you remember it's a score, a subjective score, so satisfactory, borderline, unsatisfactory. So we're going to get satisfactory if we mention all of the others. The Viva questions in this station were: how would you manage this patient? How would you manage this gentleman's atrial fibrillation? So that is both acutely and chronically. There's a question here. What would be the example of a well-answered question in relation to whether they have lung cancer? Okay, excellent question. So I'm just going to pause and just answer that question. So could I have lung cancer? So I think acknowledging the patient's concern, so saying, I understand that you've obviously read about it, and that can be quite distressing to think that, because some of the symptoms you have um, could be um, could be a symptom. You've done the absolutely the right thing by coming into hospital, so we can get this investigated. Um, and while it's something, you know, that is at the bottom of my list that I'm considering, this depends on the history that you get. You say, I actually, what I suspect is this condition here, and it's related to your heart. I think, and then you go on and explain what you think the diagnosis is. Okay, so you cannot and you should not offer false reassurance. Say, I do not think this is definitely not lung cancer. You can say, I think it's unlikely, but I would personally phrase it as, well, although lung cancer is in the, something that we always think about because we always are trained to think about the worst case scenarios. In this case, I actually think it's this, something like that on the lines. Because you need to demonstrate that you're not dismissing their concerns out of hand, you're acknowledging it, but also sort of sensitively sort of redirect them and think that this is not the ultimate cause of their symptoms and why they've come into hospital or why they're in the MAU department. Hope that sort of answers your question. Fine. So where was I? So these are the Viva questions that are asked in this station. Um, who knows the answer about is there any impact to his work? Anyone want to post in the chat what the impact to his work is? Anyone want to post in chat? Anyone remember what his work was? I don't think so. Okay, well, let's go back. The only reason why I throw this station is I think it's interesting how little the details that you get tested on. Okay, so he's a bus driver. Okay, that's right at the bottom screen. I hope it is projecting well on your screens. Okay, um, but can you see even the little minor details? Okay, because you can't get caught up just in looking at the medicine. So the question, is there any impact to his work? Well, here's the DVLA rules on atrial fibrillation. So it depends, basically. So we need to know if he's ever had any syncopal episodes. It depends on his echo, um, and if there's any sort of incapacity. So basically, if he can't safely control his or stop his vehicle, he must not drive. Um, okay, so every little thing, every little question, thing they tell you has a reason for it. So it's not just there to just be a filler. Fine. Um, if he's a bus driver, yes, I think people have picked up he's a bus driver. Brilliant. So yes, that's Right. I get asked this question a lot, and that's the suggested timings and sort of how long to spend on things. Now, I think it depends on, it sadly depends on, completely depends on the consultation that you have. Um, I would suggest that 4 to 5 minutes is spent on history taken. That's solely just taking history. So that's um, and then 6 minutes for an examination. And remember, you can continue asking questions. So I think if you've hit, so here's my thoughts. If you hit, let's say, minute 6 of the consultation and you haven't started examining, I would start examining, okay, and then carry on asking the sort of past medical history or social history at the same time as if you can, okay? So obviously you can't ask questions while you're auscultating, you can't ask questions when you're giving instructions. But if you're just feeling the abdomen, for example, then you can carry on asking questions, can't you? And that's a mechanism for distraction. So it achieves two things at once. Please allow yourself a couple of minutes to ask patients for ideas, concerns, and expectations. So basically for them to express their questions, it's really important to give yourself time because you get there's a specific domain in the mark scheme for that. And then also have a bit of time in your back pocket to explain the next steps because it's a nice transition and it ends the consultation usually. Okay. So what you don't want to do is be in a situation where you've done your history, done your exam, and then you're still sort of answering questions from the patient and you haven't really told them what the next steps are. Okay. So that would be an unfortunate sort of clunky end to a nice clinical consultation. Whereas if you sort of naturally just progress it through at a reasonable pace, you'll find that the station will end should end sort of that 13, 14 minute time mark. And just remember, use the what I suggest is use the timer when they at 13 minutes when they knock on the door or ring the bell as your marker to say, okay, here's the next steps, here's what we're going to do, and just sort of tie up the consultation. I'm just going to see if there's any questions on this. No, no comment, no questions. Brilliant. Okay, so we're on to some practice cases. I don't know if so we need 3 volunteers ideally for this to work well. So I don't know if anyone wants to volunteer. When do you advise to ask about ICE? So as soon as you finish your examination, I would invite yourself to ask at that point. Because I think you need to deal with it then, okay? Usually the first, sometimes the question is, what's the next steps? And that's fine because that answers, that sort of sorts you out for the second bit. But as you can see, the stations usually have, could this be this? Could this be serious? Could this be a stroke? Could this be, etc., etc., etc. And you have to deal with that. And I think dealing with that after the finishing your examination is sort of a very natural time point. Any other questions at all? Just waiting for 3 volunteers. I'll just be sort of pointed to do the cases myself. Perfect. We have one. We have two. Well, let's get going with our first two volunteers, and then hopefully we may get a third one. Brilliant. So we've got 3 volunteers. We'll do it in the order of the volunteers. So, sorry, my screen for the actual Zoom thing is quite small, but I think it's uh, Maishwara. Ready?
Yeah,
Perfect. Can you hear me?
yes, Mahesh already here.
Brilliant. Thank you. Thank you for volunteering. That's very kind. Um, so
Yeah,
look, obviously you can't examine because it's a webinar.
yeah,
So the purpose of this webinar, just so we get maximum learning, is I'm probably just going to give you 10 minutes, okay?
Yeah,
And what I'm going to suggest is you get a bit more time to do a history,
yeah,
just because you're sort of starting to prepare for your exams rather than in full swing. And then we'll have a 3 minutes Viva,
yeah,
okay? If there's any
yeah.
sort of important examination findings, I'll let you know at the end of
Okay.
the history, okay? But what I would like
Yeah,
you to say is when you're at the point of examining, um, you can just say what you would examine for.
yeah, sure.
Happy with that? So that's the case for all the volunteers.
Yeah, I'm ready. Thank you.
Brilliant. Okay, so this is your case. Okay, I'm going to give you just a
Yeah,
minute or two to just read that, and then when you're ready, let me know, and then I will start a timer of 10 minutes. Okay,
yeah,
perfect. I'll let you go.
yeah, yeah. Okay. Hello. Good evening, ma'am. My name is Maheshwara. I'm the doctor, medical doctor working in this clinic who is looking after your knee pain. Is it okay? I can ask you a few questions
Yep, sure.
and examine you? Yeah. Okay. As we talk, please ask me if you don't understand as many questions as you want. Okay. Yeah. Please tell me about your knee pain.
I've got really terrible knee pain in my right knee. Started about 10 days ago. Um,
Yeah.
and yeah, it just came on all of a sudden.
Okay. All right. And yeah. So is on only on one side or both sides?
Just on my right side. Yeah, it's just my right knee.
On only one joint, no other joints you have any pain.
I mean, I get the odd joint pain, but as in I'm only worried about my right knee though. Yeah.
Okay. Okay. All right. And is there any swelling of the knee?
It looks a bit bigger. But yeah, I don't really know.
And is okay. And any rash anywhere?
No rash, no,
Is there
nothing I've noticed.
any you feel any joint stiffness?
Doesn't feel stiff, it's just pain really.
Pain. Okay. Yeah. Please tell me what makes it worse and what do you do when it gets worse? You observe anything which gets worse?
I mean the thing is I mean it's only been I say it's been almost 2 weeks now, right? But
Yeah.
I think I've started taking some painkillers.
Yeah.
Um, and Although I remember going to the doctors years ago and they said, oh, you might have a bit of mild arthritis in your hip. Like,
Yeah,
I mean, that was fine, right?
yeah,
So
yeah.
this is really painful.
Okay. You have any fever recently?
Yeah, I did actually. I had fever. Um, not 2 weeks ago, maybe 3 or 4 weeks ago. Yeah, I had fever.
All right. Tell me something. If you move your giant, the pain gets worse,
Yeah, it gets
or
worse. So it gets worse when I move it, and it gets worse when I try and stand on it as well.
okay. And what do you do when it gets worse?
I try and take some painkillers, and I've tried sort of hot compressors, cold compressors like ice packs and stuff like that. Nothing seems to work, really.
Okay. All right. And you mentioned hip giant. There is some pain, and also you mentioned some other giants. You have any pain in the hands, feet,
As in I used to, as in like not right now. The only joint I'm worried about is the right knee.
right knee? Okay. And there is no back pain.
No, I don't have any back pain. No.
No back pain. Okay. Uh, you remember any injury to the knee?
No, I mean I was playing football, like not
Yeah.
properly. Like I mean I'm 70. But
Yeah.
I was just playing around with the grandchildren, and
Yeah.
I don't normally do exercise, but there was no sort of
Yeah.
like the ball didn't go hit my knee or anything like that. It was just quite easy.
Okay. And I understand there is some walking problem. What exactly? Please explain about your walking problem.
I can't stand on my knee for too long because it's painful.
Okay. Is it because of the pain or any weakness in the legs?
Because of the pain in my knee.
Because
There's no
of the.
weakness.
Okay. All right. You feel any stiffness in the joints when you wake up? Early morning stiffness?
Mm, I guess so, but I mean, it's only been a week and a half.
Okay. Week and a half. Okay. Not before that.
No, like I said, this has only started 10 days ago.
Okay. 10 days ago. And roughly how long it lasts?
What do you mean?
Like how much long the stiffness lasts?
Oh, I see.
Minutes or hours?
It's sort of there throughout the day, to be honest. I don't think it really gets better.
Yeah.
You have 2 minutes left in your history.
Okay. All right. And what other medical problems do you have?
Um,
High
like I
blood
said, I had
pressure?
arthritis, like these, I think it was
Yeah.
wear and tear arthritis. I had a heart attack
Uh,
5 years ago,
uh-huh.
and I had a blood clot, 2 years ago.
Blood clot? Sorry.
Yeah, blood clot in
This,
my leg.
okay. So for that, you taken what medication you are taking
So,
for that?
they thought the blood clot was sort of, I don't know what the word is, but they thought I had reasons because I traveled,
Yeah.
etc. And so I just took
Yeah.
some blood thinning tablets for 6 months, but I'm not on them anymore.
Okay.
Um, and then I obviously am on some tablets for my heart.
Heart. Can you quickly tell me what they are, if you remember, please?
There's something to slow the heart. There's a blood thinning tablet. There's a cholesterol tablet. There's a blood pressure tablet.
Okay. You take any painkillers, so you remember the name?
And like I said, I'm taking painkillers now. So
Uh,
paracetamol. I'm on codeine. I'm avoiding ibuprofen.
okay. All right. And the travel, it wasn't recently, long time ago you traveled, right?
I traveled 4 weeks ago
4 weeks ago to where?
to Thailand.
Thailand. Okay.
It was a bit of a tour
And
in Southeast Asia.
yeah, so is there any swelling in the calf or in the thigh?
No,
Okay.
you're out of
And
time, but I'm
sorry.
going to give you 30 more seconds.
Okay. And do you have any allergies?
No,
Allergic to any medication?
no.
Okay. And you are retired now?
Yeah, I'm retired.
Okay. But how this is impacting your day-to-day life,
I mean, I can
moving
barely
around in
walk.
the house? Oh,
Yeah,
sorry.
I can
Okay.
barely walk.
Who is
It's
help?
painful.
Any help at home?
I mean, family have been great. They've been helping, but I would quite like to get on top of this to work out, what's causing the joint pain.
Okay. Yeah. Hello.
Uh, Sorry, I'm just going to mute the other person. All
Yeah.
right.
Yeah.
End of station. Sorry about that last interruption. If
That's
Okay, I'm going to turn back into examiner mode and ask
yeah.
you what are your major differentials?
Okay. I'm going to examine mainly the uh, giant itself, the right knee giant, to look at the swelling tenderness and at the same time to be careful not to induce any pain, and then look for, because the patient had DVT, I would check for any recurrence of clot, look for any circumference, cuff circumference
Yeah.
increase,
So
and
let me tell you the findings then,
yeah,
because I think
okay,
you've offered quite a few things. So the right knee is swollen, it's hot to touch,
yeah.
and there's restricted range of motion. There's no calf swelling or tenderness. Um, Anything else you would examine?
I would examine for the heart, um, for any CCF um, findings, lungs briefly check for crackles, and pulse rate, uh, definitely pulse rate. And because she mentioned about hip pain, so I would also check the hip motion.
Okay, fine. And what test would you order?
Okay, so my main differentials will be osteoarthritis, septic arthritis because of the fever, history of fever, and trauma is at the bottom of the list, even though she gave some exercise and playing football. Um, the test will be specific tests including the giant X-ray, knee giant X-ray, taken giant effusion for cytology, bacteriology, and cultures, and to look at the turbidity. And if it is very turbid, it kind of urgent. Septic arthritis is um, medical emergency, so which demands admission and treating aggressively. Of course,
Okay,
looking for the
end of
complete blood
station.
count.
End of station. Thank you. So, first thing to say is thank you so much for
You're welcome.
volunteering. First, I can't say how it's one of the hardest things to do, especially on a webinar, to get people to volunteer, put their hands up and do it. So, thank you so much. I
You're
just
welcome.
before I sort of give you the feedback, I wanted you to tell me how going through that, how that felt in your from your perspective.
Yeah, it's a good case and common case. Yeah, but because 5 minutes, yeah, I could not complete many other things which I wanted to. Yeah, and yeah, examination and differentials, I could do few.
Yeah, so I just want to just highlight how time pressured it is, right? And I think you've
Yeah,
identified it. So I remember I gave you 7 minutes, okay? So I
yeah,
gave you half the time you would have got in the real thing just for
yeah,
history.
yeah,
Yeah. So I know you spent a tiny bit of it to talk go through ice. or ideas,
yeah,
concerns, expectations. Sorry, if people aren't
yeah,
familiar with that abbreviation. But can you see how tough it
yeah,
is? Because remember, you're not even going to talk. So at the moment, what you've done is taken a history.
yeah,
You've told me what you would examine, not actually physically examined it, because that will take time.
yeah,
Getting someone in the
yeah,
position to examine the joint, feeling it, all of
yeah,
this will take time. Okay, so you'll run out of space quickly.
yeah,
Um, Now, obviously, I wasn't, didn't give you the time to prepare for the station in the way that you would have done, which is you had 5 minutes. I only gave you a couple of minutes to prepare your differentials. Now, I'm going to ask you now, do you think there's one differential that you didn't have in your list when you had joint pain?
yeah. I was thinking about gout, but I don't have
Yeah,
any.
anything else?
Perhaps. Um, um, Sorry, I can't think.
If I prompt you and think about the recent travel history to Thailand,
Yeah.
any thoughts?
Yeah, yeah. You did told me about it. Um, yeah, DVT. Um,
No.
no,
Um,
not
just
DVT.
I'm going to tell you it. So I think a few people have put it in the group chat. So it's
Yeah,
reactive arthritis. Now, I don't think you could have made that diagnosis with the history you took. Not saying the history was
yeah.
bad. It's just because I don't think you quite got there to the point where you specifically asked me about bowel habit and it was like specific reactive arthritis questions. So here are
Okay.
my thoughts on a joint station. So I think
Yeah,
you've got to ask yourself, what are the most discerning questions about the joints? Okay, and what are associated features that I must ask in every single joint station? So here are my thoughts. So in a joint station, you must ask about the eyes. So you must ask, is there
yeah,
any conjunctivitis or any red eye? Okay, because
yeah,
that tells you a couple of conditions either way. Okay.
yeah,
Um,
yeah,
you asked multiple times about which joints were involved. I
yeah,
think I did try and say it was monoarticular. And I think as soon as
yeah,
you got it's monoarticular, you
yeah,
bring down your rheumatoid arthritis down the list. Osteo, yes, I guess you can have one joint. But things like gout and reactive arthritis, right, and septic arthritis go up the list, okay?
yeah,
Um,
yeah,
Yeah, and then you're going to ask about so you thought about travel history, and I think you did a really good history about clots and stuff. But remember that it's the joint that hurts, right? It's the joint that's specifically the problem here. Um,
yeah,
so if you asked me a few more specific questions, I would have told you that I went to Thailand, I had diarrhea, I was treated with antibiotics, and that's when I had the fever.
okay.
Okay.
Yeah,
So I think that would have got you the answer. Your clinical judgment is good because septic arthritis is the thing to rule out here, and you definitely need an aspiration for that. And you're going to do tests for hematobiochemistry, CRP. You would probably send for a rheumatoid factor, et cetera, et cetera. And you'll do a chest X-ray because on the chest there are some crackles, but we didn't get to there. Um, Differential diagnosis here. Any seropositive arthritis agreed, and any arthritis could be a differential diagnosis here. Okay, it's just that reactive arthritis is the most likely if you got the history of the diarrhea and the sort of conjunctivitis story.
yeah, yeah,
Um, but yeah, really well done. It's you can see there's a lot of information you can end up covering in
yeah,
this story. So that's what makes it a very hard exam actually. And again, it's coming back to the idea of that 5 minutes. You've got to write down every differential that's possible, and then think about what your discerning questions are to try and push you one way or the other.
yeah.
Any questions on that? No. Okay. Brilliant. Thank you so much for volunteering again.
Thank you. One, yeah,
Yeah, go on.
I need to thank you. 30 seconds. Uh, I attended the course, BitePACES course in October, and thinking to appear for PACES in November in Jamaica. Because of the Hurricane Melissa, it got postponed to March. So this session allowing me as volunteer is really helpful. Hopefully, I might get few more chances to volunteer.
No, that's very
My
kind.
exam is in March. My exam is postponed to March next year.
Well, I mean, you've got there's plenty of time. I'm sorry that it was postponed because that obviously ruins sort of other things in life. But you've got
Yeah.
plenty of time. And again, my biggest tip to anyone sitting this exam is prepare each station. Um, use those 5 minutes before to just reset in the stations where you don't have any information to read, and in the stations you do have something to read. Use the pieces of paper to really write down and plan what your consultation is going to be like. Okay. Who was our second volunteer? I think it's Portia was our second volunteer. Portia, are you still on the line? Yes, ready. Brilliant. Portia, you've seen how it's done. So you're going to have t 10 minutes in total, 7 minutes to do the history, and 3 minutes to um, for Viva. Okay, so I'm just going to give you a couple of minutes um, just to read this.
Okay, thank you.
Just want to reset my own timer. So I'm just going to answer Vanessa's question. I'm sorry, Portia, whilst you're preparing. So Vanessa, so how do you initiate ICE in the consultation? So so I don't want what I don't want you to do is ISO, I think is probably quite a UK term. But I don't want you to say what are your ideas, okay? So I don't think that's necessarily the way to do it. So I think you finish your examination and then you sit down and you say, okay, Mr. Brown, Portia, ignore everything I'm going to say for now. But I think that the cause of your symptoms could be this. Have you heard of this before? That's if you know the diagnosis. If you don't know the diagnosis, you go, well, Mr. Brown, I think what we need to do now is we need to do a few more tests. Okay, so I think I would like you to come into hospital and we do this, this, and this. Do you have any questions? Okay, so open question. Do you have any questions? And then you can, if there are some questions that are left after you answer his specific ones, then you say, do you have any particular concerns? And and you can ask, do you have any idea what could be causing this? Is how you ask ideas. And in terms of expectations, you can say, is there anything, what are your expectations out of this consultation? Now, the last question that I've just phrased, that is only necessary if the other two don't exist. Okay? So I think the most important thing is after you've done your examination, you're going to just quickly summarize your thoughts to the patient and you say what either your plan for your management or what you think the diagnosis is. You then say, well, do you have any questions about this? And then you say, you know, can I ask if you've got any specific concerns? And then you sort of let them come back. Okay. Now, if, for example, they have no questions and you do not know the diagnosis, you can then ask, do you have any idea what could be causing this? Okay. And if they don't have any idea and if they have no concerns, you can just clarify with expectations. So I would personally suggest that you do not ask all three questions in the consultation because I think that takes too much time. Okay, because they are geared ready to give you the questions they want you to answer already. Okay, so you're going to find their ice inverted commas already. Portia, that's probably enough time for you to prepare. I'm sorry for talking over whilst in your preparation time. Um,
Okay, that's fine. Should we start?
Yep, whenever you're ready.
Hello, Mr. Brown. My name is Portia. I'm one of the doctors here in the unit. I understand you've come with a headache today. Is that correct?
That's correct. Yeah.
Okay. Would you tell me more about this headache, please? When did it start?
Well, I came to the emergency department a few hours ago because I developed a like the worst headache I've had. It's sort of, I don't know. I mean, sort of came
Hmm.
a few hours ago. Um, just sort of
Okay.
kept getting worse and worse and worse, and then I just thought, I took some paracetamol and nothing happened. So I thought I was worried. So I came into hospital.
Okay. I can see that you're quite worried. We'll see how best we can assist you today. So where exactly is this headache? Which part of the head is it?
Yeah, so it's sort of I don't think it's sort of all over. It's sort of all over my head. Like it's
Okay.
but sort of like here mainly. So like a band around my forehead, just for people that don't have video.
Okay. All right. And is it at the back? Does it radiate to anywhere?
It's not at the back really. It's usually at the front. But it does feel like it's just generalized. It is everywhere in my head.
Everywhere in your head. Okay. All right. And you did mention you're taking paracetamol, but that's not helping. Is there anything that's making the pain worse?
I don't
When you're,
I've not
is there
I've not noticed
anything? Sorry.
I've not noticed anything making it worse, no.
Okay, when you're bending or anything, it's not getting worse.
Um no, no.
Okay, all right. Do you have any vomiting with this headache?
No vomiting with this headache.
No vomiting. Okay. Um, do you have any fever by any chance?
No fever.
No fever. And any history of trauma or banging your head anywhere?
Neither.
Neither.
No.
Okay. All right. Um, I understand you've been treated for hypertension as well.
That's right, yeah.
Okay, all right. And has that been controlled over the time?
I don't know. I haven't really been checking it. All I do know is that recently the GP started me on some medications for it.
Okay, all right. And would you know what medication that is?
Oh, it's Ramipril.
Ramipro. Okay. All right. Thank you for letting me know. I just want to find out if you have any weakness in your body or anywhere, any part of your body.
No.
No. Okay. And your eyes, any blurred vision?
No, not really.
Okay. All right. And do you have any family history of hypertension, of high
Um
blood pressure?
yeah, I mean I think my dad had high blood pressure, but that was it.
Okay. Any family history of any kidney problems before or any cysts in the kidneys?
No, I don't think so.
You don't think so? Okay. All right. Do you have any pain in your tummy yourself?
No,
No, okay. All right, that's fine. Any past medical history other than the hypertension you've told me about?
no, nothing.
Okay, all right, thank you. You did mention you're on amlodipine. Any other medication you're taking at the moment?
No, just that and the paracetamol, which obviously isn't
Okay.
working.
All right. Any known allergies?
No, none.
All right. Do you smoke?
Yeah, I do smoke.
Okay. How much?
10 cigarettes a day.
Okay. All right. And who do you live with?
I'm married, and I've got two grown-up children at home.
Okay, that's good to know. Any recent history of travel?
No, no recent history of travel.
Okay. And if you don't mind me asking, do you work?
Yeah, I work as an IT consultant.
IT consultant. Okay. All right. Thank you. Is there anything that you're particularly concerned about today?
I mean, it's really bad, this headache, and it's been there, it's not the first time. But like this is the worst headache I've had.
Okay. You mentioned it's not the first time. How many times do you have the headache?
So I'm getting it every sort of few days for a while now.
Okay. And is there any thing, do you have any symptoms just before the headache starts?
No, I mean, no, not that I can sort of recall.
Okay. All right. That's fine. And any eye symptoms associated with the when you have the headache?
Um, no, I don't think so.
Okay. All right. Thank you for that. Um, I'd like to perform an examination if that's okay.
Okay. Wait, what are you going to
So
examine?
we've discussed about your headache. As you mentioned, it was quite an acute onset. It's the worst headache. I'm quite concerned about one condition that is called subarachnoid hemorrhage, which could be a bleed in the brain. Um, Although would like to do other further investigations as well. Uh, and for now, I'd like to examine your neurological system just to check if there's any associated weakness or any asymmetry from caused by the headache, and examine your eyes as well to see if it's affecting your eyes. I'd also like to examine your abdomen to see if there are any
1 minute left.
masses in the to see if there are any masses in your tummy. Is there anything else that you would like to ask me that you're concerned about? Besides, I know you've told me about the headache.
Well, I mean, the thing I was reading about, was about brain tumors, and because it's been 3 months of these headaches now, and they are, I mean, this was the worst one. I just wondered if that's a possibility before I got
Um,
silly.
Thank you for sharing your concern with me. So, given the hypertension and the acuteness of the headache, I would like to rule out the subarachnoid hemorrhage. However, a brain tumor could be a possibility, but it's something down on the list. Hopefully, from the investigations that we'll do, we'll be able to find out what exactly is causing this headache.
Okay. So we're going to move on to the Viva section.
Okay.
Um, what investigations would you order for this patient?
First of all, I'd like to order I would like to repeat. I would like us to do some observations.
Yep. I'm just
Uh,
sharing. I'm just sharing my
Okay, I'd like to do some observations, and ideally, I would like because it's worse headache. I would like to do a CT scan of the head to rule out a possible bleed in the brain, CT non-contrast, um, and I'm quite concerned as well high blood pressure. I'd like to do ultrasound abdomen as well to rule out any polycystic kidney disease and also the renal system to rule out any renal artery stenosis because it's quite a young patient with hypertension. Um, Depending on the what we find on the CT head and with the differential diagnosis, we may need to do what we call a lumbar puncture just to help with the diagnosis as well.
Okay, fine. I'm going to end the station here.
Okay.
No, that's not as it's because you sort of answered a lot of the questions I was going to ask. Anyway, um, right, Portia, how do you think that went, first of all? And again, just to emphasize it, it's thank you again for volunteering. It's super helpful, and I think it's really educational for everyone on the call when people do volunteer. Could you just give me a bit of insight, actually, um, into how you generally thought it went and what your thoughts were before you'd even started the station?
Um, so when you see the station, like a lot of things come up in your head and it's easy to sort of like get confused. But I started to lay down the diagnosis and try to figure out what I need to ask to rule out this because I was thinking of hypertension, young patient, subarachnoid hemorrhage, most likely, and I also tried to rule out meningitis. Um, but one thing for me, I think just moving from one system, history taking, and then going to past medical, then go back to history is also one thing I just need to work on as well. And probably having a wider range of differential diagnosis because I didn't think of a tumor as well. I was sort of fixated on one diagnosis, and yeah,
Yeah.
that's how
I,
I felt.
I think that's a fair thing to say. I think you made a very quite an advanced diagnosis actually. I was, I mean, it's a very clever thing to think about, just as a because it's not even on my list of things. But but I know as in I definitely support it. I think just take a step back and just think about it for a second. So this is a 43-year-old
Uh-huh.
presented with a severe headache. For, he's had it recurrent. So one question, so this is that one question that you need to ask and you need to write down in the 5 minutes. So headaches, there's
Uh-huh.
there's two specific questions that you have to always ask with headaches. Okay, so
Okay.
if you think it's a benign headache, so like a tension headache, migraine, you need
Mm-hmm.
to ask the person that has it, how long does it take to get to the peak intensity?
Okay.
Because if it's a subarachnoid hemorrhage, for it to get to peak intensity, it tends to be quite quick.
Okay.
Yeah, remember it's sudden onset, etc. But if you ask him specifically, okay, so actually, how long did it take you to get to the most severe of your headache or the most peak intensity of the headache? The answer is actually in his patient sort of brief. It's actually
Okay.
about 45 minutes to 1 hour, which
Okay.
makes it more benign. Okay. So that's the
Okay.
first thing. The second thing to say is the recurrent nature. So that's another clue because he's not having multiple subarachnoids, is he?
No.
So he's got something in the background that's happening. Now, you could be absolutely right though. Those headaches could be different, right? Someone can have a history of migraines or tension headaches and
Mm-hmm.
then have a subarachnoid. 100% fair enough.
Okay.
But you just need to work out what the other headaches were. So I
Migraine.
yeah, so I would ask a few more questions. Really sort of straightforwardy ones. So, are you staring at a computer screen? So, do you wear glasses? Have you changed your vision, etc.? And you will say, look, I
Mm,
changed my reading glasses around about the same time. And he's also started drinking lots of alcohol because he's more stressed. So
okay.
these are the things. So the differential diagnosis, the answer is tension headache, is what they've suggested.
Okay.
Um, but I really did like the way you thought about that because I think that is, that is actually quite sort of what they do in PACES. Um, Fine. Okay. So, um, so yes, migraine, alcohol-related headache, hypertension, sort of a
Hmm.
hypertensive headache could also be a possibility, couldn't it? So I would try and include more common things in your list.
Okay.
I think it's reasonable to think about a subarachnoid hemorrhage, but then I think you've got to ask yourself, why do you think it? Yeah, so you're going to keep searching for it because you're happy that meningism or meningitis is sort of excluded. There's no history of fever, no rashes.
No.
Okay, so you're happy that. So again, do the same thing with subarachnoid if you can. Um,
Okay.
and then in the examination, I would try and do fundoscopy
Okay.
before I examine the abdomen.
Okay.
Yeah,
Yep.
are you happy with that? Anyone else have any questions on that as well? Just put it in the chat.
Yeah, I'm happy with that. Okay.
Yeah, so the person who has said Koenig and Brzezinski, which is the signs for meningitis or meningism even. I wouldn't do it in this exam. Okay, so I wouldn't do it for the station because there's nothing really in the history that's hallmarking meningitis here. Okay, so there's no fever. So Portia's taken a very good history in that she's she's made this very unlikely. Okay, so I wouldn't go searching for that as a diagnosis. I think looking at the back of the eyes for papilledema, see if the discs are raised, doing a brief neurological exam. So what does that include? You're obviously going to focus on the head and neck, do more cranial nerves, and then you're going to move down, just get them to walk, just move their limbs a bit and check their reflexes just to prove that there's no focal neurology. Okay. And then again, that would go against the subarachnoid hemorrhage. So yeah, so that's what I would do. So it can still be the worst headache of your life. It doesn't mean it's a meningitis or it could be subarachnoid. Yeah. So it can still be the worst. There's no reason why that's not factually correct. Um, that's an example of a red herring, okay? Um, because remember I said it was frontal, okay? Mainly.
Yeah. Yeah, and tension, a bend like as well, you did mention.
Yeah. So I threw one red herring, but I think I was fair enough to
Yeah.
bring the other stuff back. But look, this is learning. This is the time to make those things. And also, I really will emphasize how good that was to come up with the other bit. Okay, we're going to do the last case. I'm sorry that we ran over time, but I think we did start a bit late. So our last volunteer, this is your station. I'm going to give you a couple of minutes and then we're going to go straight into it. Is our last volunteer still on the call, actually?
Yes, yeah. Yeah. Thank you.
A bit. Let me know when you're ready, Sabrina.
Yep, I'm happy to go ahead.
Brilliant. I've started the timer.
Okay. Hello, my name is Sabrina. I'm one of the doctors here at the clinic. Can I just confirm your name and age, please?
Yes. So it's Mr. Harry Smith, who's 75, and I'm his son, John, who's also here in the clinic.
Okay. Hello, nice to meet you both. So, how are you doing, sir?
Yeah, I'm good, thank you. I'm just a bit worried about my dad, who
Mm,
who's not been well for at least a couple of months now. He's been just feeling sort of tired all the time. Um, and yeah, actually, he's a bit unsteady with his walking. It just seems a bit, restless.
fine. And did this all start 2 months ago? Everything?
Yeah, well, it's sort of, I don't know what started first, but it just feels like everything's just been getting worse. And then, so we've
Mm,
been seeing the GP, right? And they actually are the reason why we're here because the GP said there was a blood test that was abnormal or something like that.
okay. Did they explain to you what is abnormal or?
No, they just said that, we need to go to hospital. She didn't
Mm,
really tell
mm.
us the problem.
Fine. I'll just ask you a few more questions about your dad, if that's all right, to figure out what's going on, and then we can make a plan and see, and I can explain to you what we'll do for him as well, and take it from there. How does that sound?
Yeah, that sounds great.
Okay. So you mentioned your dad has been feeling more tired over the past 2 months, and also some balance problems. Is that right?
Yeah, I mean, it's not, I guess it is balanced, but he's just sort of been unsteady on his feet.
I
He's
see.
he actually forgets things and he's not concentrating on stuff. And like I
Mm,
said, he's just yeah, I don't know if restless is the word, but he's not quite himself.
okay, okay. Have you noticed anything else about him that's different from his usual self?
No, I mean not that I can think of straight off the bat, no.
Okay. Any personality changes or just feeling more tired than usual?
Not personality. Like his memory is just not as sharp as it used to be.
Okay, okay. And um, has this been gradually getting worse, or do you feel that it suddenly got a lot worse with
I
him?
don't. I mean, my dad's memory is not perfect, but it's not like it's not bad, you know. And I think the last couple of months really has been, yeah, it's been shocking, a shocking decline.
I see. Okay. And have you noticed if he has had any weight loss?
Yeah, he's actually lost probably about a kilogram or two in this sort of last couple of months.
Okay, I see. And how's his eating?
His eating is okay, so he's got an appetite. However, he has been suffering qu quite bad heartburn and sort of acid reflux, especially if like it's a decent sized meal or if he eats late.
Mm-hmm. And has he, so who's with him at home? May I check, please?
Yeah, so it's my mum, and I mean, and I sort of live nearby him, so I'm only a couple of doors
Mm,
down. But it's just my mum and my dad together.
okay. Has he had any like night sweats or weight loss? Oh, sorry, or fevers?
No fevers and no night sweats.
Okay, okay. Um, and with regards to his health in general, any other medical conditions?
So quite a few years back, maybe three or four,
Mm,
he did have blood in his stools, and I think they diagnosed him with diverticular disease and a polyp. The polyp was removed, it was all fine, and that was put to bed. But apart from that, there's nothing else that he has. He's pretty healthy actually, which is why this
okay,
is all surprising.
okay, that's good. And does he drink alcohol?
Not anymore, no.
Okay. Any smoking?
He's never smoked.
Okay, that's good. And does he have any allergies?
No allergies.
Okay. And just in general, th has he ever mentioned any changes in his vision?
No, there's no change in the vision. No,
Mm. Any cough or shortness of breath?
no,
Okay, not bringing up anything, coughing up blood and things like that.
no, not at all.
Okay.
Got
Um,
2 minutes left.
sorry,
Got 2 minutes left of your history.
has he had have any tummy aches?
No, no. I mean, apart from that test a couple 3 years ago, nothing in his tummy.
Okay, and any chest pain?
But I mean, sorry, just about the tummy pain and slash chest pain. It's heartburn. It's definitely heartburn.
Okay.
He's on medication for that.
Okay. And any changes in his how often he goes for a wee?
No, nothing, no difference.
And no blood in the wee.
No, not that we know of.
Okay. Any changes in how often he opens his bowels or any constipation or diarrhea?
No, and there's no blood in his stool either.
Okay, that's fine. All right. I'll just check him over and then probably we'll need to do a few more tests to to have a look at what's going on. We can send off some blood tests to just repeat um it to confirm because from your GP, I think one of the um abnormalities that they found was a low sodium. That's one of the salts in the body. There can be many different causes for this, and likely this can also quite a very low level can affect um how people walk. So he might be more unsteady on his feet, and it can also sometimes also make cause some memory issues as well. But we need to find out there's many different causes and we can do some tests to find out why it's low. We'll probably get some scans for him as well. Does that make sense so far?
Yeah, I mean, what do you think is wrong with him?
There can be many different causes. With regards to what you're telling me about the tiredness and weight loss as well. I am concerned that if there is some form of malignancy, which is why we,
Sorry, is
sorry.
sorry, when you say malignancy, what do you mean by that?
So it can be cancer that could be
Oh, you
caused.
think this could be cancer?
That's one of the causes that I think we need to definitely work to at least rule out. But there are other things that also can cause a low sodium, and in general, that can also cause people to be slightly more unsteady on their feet and tired. Um,
End of station. I gave you an extra minute. Sorry.
okay.
Time for Viva. So what would you so let me tell you the examination findings. What did you want to examine actually?
So I would like to review the patient have a look at him in general, maybe fluid status, hydration as well, any signs of cachexia. Um, I'd like to have a quick listen to the chest for any crepitations, which would be consistent with some form of consolidation in the lungs. If I'm
So
still
his hands are warm and well perfused. He's got a
any signs of clubbing, sorry.
no signs of clubbing. His heart rate is regular at 86 beats per minute.
Mm-hmm.
He's not got an elevated JP. His chest is clear, and he has no peripheral edema. His heart sounds are 1 and 2 with no additional heart murmurs.
Okay, fine. Thank you. And in the abdomen, I guess no masses
No
palpable.
organomegaly palpable. Okay, so what investigations would you order for this patient?
So, after repeating the blood test to confirm hyponatremia, I would like to also investigate a cause of this. So, I would like to send off additional serum osmolality paired with urine sodium and osmolalities, check the thyroid function and cortisol levels, and do some first line imaging, such as a chest X-ray. And if that's unremarkable, and if depending on what the blood test results show, a CT of the chest, abdomen, and pelvis with contrast would probably be helpful to look for any other malignancies that I'm suspicious of.
Okay, fine. And what is your differential diagnosis then?
So, um, I think I would definitely like to rule out a malignancy that has caused a hyponatremia, which could be due to a small cell lung carcinoma causing a syndrome of SIADH. Um, but depending on what the further hyponatremia screen shows, I guess hypothyroidism could also be a cause of this.
Yep.
Yep.
End of station.
Okay.
Um, right. As I've said to all our volunteers, Sabrina, thank you so much for volunteering. Like I said, it's really helpful. Um, it's a slightly different style of station because you had a few blood results to work with. Um, I think the history, because you took it from a surrogate, not the actual patient himself, but you would have examined the patient, was interesting, um, as a thing. Um, oh, sorry. No, that's not a change of slides. Okay, so I think the only thing I would add to your differential list was someone's already put it in the chat, but the PPI causing hyponatremia. Um, now, from real world experience, as an endocrinologist, I don't really think PPIs cause much significant hyponatremia, um, because um, it, you know, we loads of people on it, and loads of people do not have hyponatremia with it. It would be something that you should mention because it will come up in the differential list, and then you'll just suggest that you'll switch the drug to a different class. Um, but I think you need to. I think saying SIDH, correct cause, malignancy, etc., is exactly the right thing to do here. I think you handled you sort of recovered when you said, because you said malignancy first as jargon, but I think you sort of explained the possibility of cancer relatively gently. Um, but I think if you had your time again, I think you would probably avoid the jargon in the first place and then just say, um, I think we need a few more tests, and just almost wait for someone to come back to you and say, could this be cancer? Um, I think you sort of put yourself under this microscope a bit if you volunteer malignancy as your as the thing that you're looking for when you've got very little tests going forward.
Yeah, fair enough. Okay, that's very helpful. Thank you.
MPH, yeah, so the unsteadiness on the gait isn't very clear, is it? Because if it's sort of just sort of dizziness or lightheadedness, it's not necessarily sort of wide-based gait or etc. So it doesn't it's a good thought, but it doesn't scream MPH. Um, I think it's pushing you down a different route. And really it's like trying to test your knowledge of how you do manage someone with hyponatremia. So the next Viva question, if we had more time, would be what would the management be? And just for the interest of time, I'm going to say it's fluid restriction. And then you may consider a V2 receptor antagonist such as tolvaptan if you're not winning. Brilliant. Any questions on that one? No. Okay. Right. So let's try and summarize then. So we've done three cases and we worked through example. I've tried to select things that are slightly different. Um, I, I think the clinical consultation is the closest station that, in my mind, resembles real life practice. So it's sort of the ED style clerking. Okay, you have to prepare for the station before you go in. So that 5 minute is really, really important. I can't emphasize that. If that's the only thing you're going to take away from this session, please take away that. Um, and the final thing is also think about safety points. Okay. So Sabrina actually sort of touched on that. She was starting to think about how this patient lives at home, right? And if there's a question, that she has enough information to answer that. Like I said, the aim is to be a medical registrar, so it's about logistics as well. Um, I invite anyone to sort of ask any questions about any of the cases or about PACES in general. But thank you for listening.